thank you for having me here in this meeting. I also thank AstraZeneca for this opportunity. So let me just call on the panelists. We have Dr. Sushant.
Yes. Hi, good evening. I'm there.
Hi, good evening. Dr. Sumant. I don't think we have Dr. Sumant. Dr. Anita Ramesh. I don't think she's there. Okay. Dr. Basade.
Yes.
Yes. Okay. Dr. Ashish, I can see. Yes. And Dr. Srinivas, I saw. Okay. So great. Let's get started. Okay. So we'll go ahead with the case for first line small cell lung cancer extensive stage. So here's the patient, 62-year-old male, heavy smoker, presents with cough, breathlessness, weight loss, early satiety, found to have a massive liver enlargement. Scan shows a lung mass, mediastinal lymphadenopathy, hepatomegaly, and biopsy of the lung shows involvement by small cell lung cancer. It is IHC positive, and a brain MRI was also done, which shows no metastasis. So this is extensive stage lung cancer with liver metastasis. So let's start. Dr. Sushant, how are you thinking about in this group of patients? We finished the staging workup, we have a diagnosis, and what are your thoughts in this kind of a patient?
Sir, definitely this patient requires a EP protocol, etoposide platinum, and the choice of platinum would depend on his 2D echo status and creat clearance, and I suppose that is all right in this patient.
Okay, right. So you are happy with cisplatin, carboplatin both, right?
Yeah, I'm happy with both of them, and either of them would be fine with me.
Right. And how many cycles, and what are your views on other chemotherapy regimes?
I usually give 3+3. After 3 cycles, I do a PET scan and then consolidate with 3 further cycles. And other chemotherapies such as irinotecan and all have not shown that great response compared to the old time tested EP. So EP still remains the standard of choice for me. And 6 cycles is what I prefer in my clinical practice.
So absolutely what I think all of us follow: 3 cycles EP, do a scan, see response, and then 3 more cycles. So I think all of us go for 6 cycles. Irinotecan has a limited role, but I agree with you. All of us good. Platinum Eto is good for us. So now we come to the thought of the newer therapies. What now? Not new now. We have it for a few years, but I think all of us are slowly gaining experience. So let's get to the thought of the immunotherapy combination. So Dr. Basade, how are you thinking about for immunotherapy with now in extensive stage small cell cancers for first line setting?
Hi, good evening. Yeah, yes, in extensive stage, small cell lung cancer, immunotherapy has a role now, which is established. Both the drugs, durvalumab and atezolizumab, have shown good response. And previously we have only anecdotal patients surviving beyond 1 year or 2 years, but now there are a lot of patients who are surviving even up to 3-year data is also there. So the first question, which platinum, I do agree that performance status, creatinine, 2D echo matters, but again, the brain presence of metastasis into the brain is also one we take into consideration, because what immuno I'm planning. Because if there are brain mets, then atezolizumab, probably those patients were excluded in the beginning. So I would can use the cisplatin and etoposide and durvalumab, or carboplatin, etoposide, durvalumab, like that.
Right. So there was a difference, as Dr. Basade is telling us, in the trial designs of using brain metastasis patients. I think we will just show that slide again as we go further. So Dr. Ashish, is there any patient, so cost aside, I know cost is our limitation for all our patients, but if cost aside, is there any patient you would not offer immunotherapy, at least talk to your patients about immuno in the first line setting, or all patients in first line is where you think about in small cell?
I think we have enough data to say that a combination is superior. So unless until there is a contraindication immunotherapy, I would go with the combination, and most of our patients, provided they are affordable.
Right, right. So I think now there's hardly anyone we can actually say no immuno, except if we rule out those immuno contraindications per se. That's the only thing. Otherwise, absolutely, in the present era, I think all of us, if our patients can afford it, we would want to offer it. So we have seen the clear improvement, though the issue used to be the survival benefit, the magnitude is to be, we used to look at the medians, we said in chemo era, we got 8 months, 9 months, and with addition of both the immunotherapies, we have approvals for durvalumab, atezolizumab. We saw the medians went up to about 12 to 13 months with a hazard of 0.75, 0.76. So there's always that talk, are you impressed with the medians or are you not happy with that? Dr. Srinivas, what do you think? Are you okay with that median number? Do you think it's not a great benefit?
I think still we need to wait for more matured analysis, probably that would give the answer.
Okay, so you kind of think that 2 months is not good enough. What do you think, small cells?
I think because we are talking about a population which is a very extensive stage, small cell carcinoma, very aggressive disease. Whatever the benefit, it's a benefit.
Absolutely. I think in small cells, this is the way we will go forward. You will always get that small benefit and then you'll probably keep adding on. But I think we should not look at medians, because once we see our survival curves, what we see clearly, I think I'll just get to those curves. Yes. What we are seeing here is we have the 3-year overall survival. And this is something that we have not seen till now in the small cell space. The immunotherapy data is at 3 years, showing 5.8% patients were surviving in the chemo arm. It's 17.6% in the Durva plus chemo arm. What we're seeing, tripling of the overall survival. And it's clearly significant. It's 12% more patients than what we see till now, what we have seen in small cells. As Dr. Vasade mentioned earlier, we hardly had any patients. You can remember your patients who crossed 2 years. You'll have it in your fingertips because there are so few of them. But now we are starting to see that number is getting slightly bigger. And this is the whole benefit of immunotherapy. You'll start seeing a little bit of the flattening of the curve, though it's not as great as what we see in non-small cells, but definitely it is benefiting, and the curves are clearly separating. So one thought is, any takers on why is it not showing that great response? We are saying these are all smoker populations. They are the ones which will have a lot of mutations. We kindly say all small cells do very well in terms of the ideal immunotherapy candidate. So any takers on why is it not showing that great response in terms, like in non-small cell, we see a huge number of patients doing better compared to this. Any thoughts on this?
I think it's because of the tumor heterogeneity. Lot of antigenic stimulations and lot of tumor heterogeneity is there in small cell. If we see neuroendocrine also, grade 3 also behaves like small cell itself behaves like small cell, and we have so many combination of various genes which are acting and antigens. Probably that is the reason that we don't get that great benefit as we expected.
Yeah. So what's been kind of explained is that even though you have a huge mutations, you clearly have that in small cells. They're all smokers. So you have a lot of mutations. But for various reasons, you have one of the most immunosuppressive environment in a small cell. And that is what is causing a problem. Though you have mutations, you have a very much immunosuppressive environment. So your T cells are not getting active enough to kind of get that sustained durable response which we are seeing in other malignancies where you have a high TMB. So that's the rationale they're giving as of now. But it's kind of very, very counterintuitive, and we keep thinking, these are the ones who should do really well. But again, we are slowly moving upwards, I would say that. So looking at the other issues, we're looking at the study designs, and so this is a question which gets stuck in clinics these days. When you look at both the patients, durvalumab, atezo, both are approved. How do you choose between one of them, and what are your thoughts? Ashish, how do you think about in your patients?
I think both IOs has been shown, and there is no head-to-head comparison. But cross trial, we can say this is some patient profile, because both the patients having a little bit difference in the trial, because in atezolizumab only carboplatin is allowed, and in durvalumab cisplatin and carboplatin both are allowed. So it depends on the treating physician preference. I do consider cisplatin in a majority of patient, provided it is not contraindicated. So and that's score for the durvalumab. Otherwise, if I'm using carboplatin, I think both are the same as far as the efficacy is concerned. Some patient of the brain metastasis, I think durvalumab has the better data if the patient is, because in atezolizumab, they have included only patient who's treated for the brain metastasis. While in durvalumab, even asymptomatic brain metastatic patient is also included.
Right. So this is what Ashish has already now mentioned to us clearly. So we had that brain metastasis untreated were not allowed in the atezo trial, and there were over 10% patients who had received. But in the Caspian, we had patients who were allowed both treated and asymptomatically untreated, and the cisplatin, carboplatin, and the other difference was 4 cycles versus 6 cycles. So in Durva, you see that you kind of got the ideal real-world treatment which you get for most of your patients: 6 cycles, platinito, and cisplatin carbo, or with radiation, without radiation. So all of that group of patients is there, and we have seen the clear benefit there. These are the cross-trial curves. We don't usually just compare it and say that, but if you look at it, they're kind of very similar. And if you look at medians, again, they are very similar. It's kind of reiterating our fact that immunotherapy is giving benefit in the first-line setting. It's helping us emphasize that this is the benefit we are getting, and we are hoping to get long-term data sets. And Caspian has 3 years data, IMpower still has 2 years data, but we are hoping that we'll probably get longer and longer data sets. So this patient gets on to Durva and gets a good response after 4 cycles, everything goes down, and then this patient is on durvalumab maintenance. And you do see such patients in clinic. We have some patients with long-term maintenance going on, though the numbers are few, but we do see that in practice. I had a question here. Now, Dr. Basade, what are your thoughts if this patient had liver mets, but had a little bit of altered liver functions? How do you think about immuno in this group of patients? Are you comfortable because of liver mets? Maybe the liver enzymes are 2 times normal, 3 times normal. Are you kind of worried of using immuno or no?
Yes, I mean, but in such cases, I would go ahead with the chemotherapy first in the first cycle. Once the liver enzyme settle down, then I will add the immunotherapy afterwards.
Right. I think that's probably the wisest thing to do in such situations. Just give your first cycle chemo, see the liver functions, whether they're settling down, and then probably add in. And I kind of think definitely a good idea. Dr. Sushant, if you had a little bit of a raised creatinine, are you hesitant of using immuno? Or so suppose you had a creatinine of 2, would you be hesitant of using immuno in this group of patients? What are your thoughts?
So I would definitely use carbo and not cisplatin first of all, and then if I think that is disease related, so I'll use first cycle without immunotherapy, and next cycle onwards, if the creatinine improves, then I'll add immunotherapy.
Right. So all of us do this in standard practice. We are very hesitant to add in the immuno if there are some dysfunctions. Though there's good data about at least liver, about kidney, there's really good data. If creatinine clearance is above 30, there's no contraindication per se for most of the immunotherapy drugs. It's said that you can use it safely. But for liver, we need to be a little careful. They have not been studied when liver enzymes are more than 3 times normal. So we need to be a little careful when we are using immuno with liver dysfunction. But I would say, in all practicality, we know most small cells will respond at least initially. So doing first cycle of chemo and then adding the immuno also makes clear sense. And that's what even I would kind of do in clinical practice. You gave your patient, you got a good response. Dr. Srinivas, now your patient is on maintenance with durvalumab and doing well. Would you consider PCI for this patient now in extensive stage?
No, sir. I don't do PCI unless the patient is symptomatic for brain mets.
Right. So you're following the Japanese data, which is no PCI. I kind of think it's kind of, we've gone through that whole loop. We talked about a lot of PCI earlier because of the European study. That was a long time back, but we used to give PCI to extensive stage to patients who responded. And then you had the Japanese study which said that there's no benefit of doing PCI as long as you're doing good surveillance. Actually, the PCI patients did worse. So even we don't use PCI except in very selected patients. Even we avoid PCI in patients who have responded well in extensive stage. So I think,
as you alluded in the prior trials, even those patients who are having the brain mets were allowed in the one of the studies, IMP 133. Probably, I think drug will take care of that probably, and especially if the patient is on maintenance therapy, if the patient is stable and doing fine, I think.
Right. No, but we keep extrapolating our limited stage data. If our patients respond so well, PET becomes negative in 3 months, we get so excited in small cells, and then we think, oh, maybe let's do it. And I don't know, we don't have data about the immunotime. This is
my apologies, sir. You are left with 5 minutes to conclude your
sure.
discussion. Thank you.
Run through it. Right. So the other thought was radiation to chest. Ashish, do you radiate the chest after treatment if your response is good?
So I think even which you were talking the last slide, the brain metastasis, I think we have this data for only chemotherapy, which Japanese is negative and the ERTC data is positive. So like we don't have a data for the immunotherapy patients. The patient is taking immunotherapy and doing good. I think there is no definite data to support that. But in our practice, if the patient is receiving chemotherapy, they have an extra thoracic disease are completely controlled and the residual lesion in the chest, I think I do give the consolidated radiation dose scenario, provided patient is not only taking chemotherapy.
Right. So I agree with that. Selected situations, all of us are doing radiation to the chest. Though selected patients, we have to choose our patients well, but there is some data that the benefit is there if the number of metastases was lesser, if the burden of disease was lesser, which is kind of common intuitive for us. If the burden is lesser, probably radiation as consolidation will help.
Dr. Amit, I just sorry to interrupt you.
Yes.
Do you believe that concept of making the tumor hot by giving radiation, and would it help?
That's a good question, because we keep thinking about what way could we get immune to respond, But I don't think in small cell we'll definitely be able to do it. We have been thinking about it in other tumors, but small cell is very different, I really don't think SBRT will include and increase our immune responses. There should be something else also there. That's the thought. But it's a good thought that maybe adding SBRT, and that's the reason why we keep adding it these days with immunotherapies. So we have clear-cut algorithms, and all of us kind of follow the same thing. I think brain mets was mentioned. Dr. Vasade clearly said because of the data sets which we had, he would prefer durvalumab because durva has more data in brain mets, and this is what we saw in the Caspian data, that patients with brain mets showed equally same benefit as the patients without brain mets. So lastly, a quick word, Dr. Sushant, do you do any biomarkers in small cell? Or are we reaching there?
No, sir, I don't do.
Nothing, absolutely nothing. So TMV, we know, though we have high TMVs, we have very, very less sustained benefit. And we saw the trials looking at TMV, which are negative. And PD-L1 in extensive stage small cell is about only 5%. It's very low PD-L1 status, and it's really not helped. So no biomarkers. And last, maybe I think we were told time is up. So let's kind of how do you kind of look at managing poor performance station patients? Dr. Vasade, your thoughts on that last question? Poor performance station patients with small cell?
So I will try to find out the poor performance status is because of what? It's because of the brain mets. Then we can treat and then treat the systemic disease. If the poor performance status is because of the large mass which is causing SVC obstruction or pericardial effusion, then you can do the pericardial tapping or pleural tapping and treat accordingly. So, you need to individualize the treatment. It's not that poor performance status patients will not do well at all. It's not. So you have to look into individual patient.
Right. I kind of agree with Dr. Vasade's thoughts. And I think this is becoming very important nowadays, because in many cancers, we are seeing responses can be got better. So it's not like the old algorithm where we said patients with poor performance, just leave them alone. There are ways by which you always say, if your poor performance is due to disease, and if your disease can respond, your performance status will improve. So I kind of echo those thoughts what Dr. Vasade has said. Always, if you treat the disease, if the disease patient gets better, their performance status is going to improve. So choose your patients very carefully. So I think with this, we will summarize. We have clearly seen first line IO plus chemo in small cell lung cancer clearly has made its space. There's really no doubt about it, though the increment of benefit is smaller. But now you have 3 years data clearly showing a tripling of overall survival. And I think this is the most important factor, the durability of response. And these patients can be kept on maintenance. So a quick word on safety. It is very safe, and though we know we have to watch for IRAs, but we know, and all of us are getting experience in managing IRAs. So I think that's something we're all confident about. So with this, I thank all the panelists and I thank the organizers. I think I will stop now. Thank you very much.
Thank you.
Thank you, sir, for such a good moderation. It is always that in small cell, it is like it approaches so close, we get a good response, and then we know that we are going to fail. It's kind of place where you want to know where did we go wrong, kind of a scenario. Is it, what can we do to achieve a better survival? We end up knowing that they are not going to do well, but still we want to do something, which is kind of a tricky situation.
Absolutely, I agree with you. It's one of those situations where in your gut, you know, long-term may not be good, but you still get the euphoria when they respond.
Yes.
You in 3 months, you're so happy to see that response, and you still know, yes, it will not last, but you always want that to last. But I think this kind of a data showing 3 years, 15-16% is kind of very getting impressive. But I definitely think we need better things, and somehow if we could add on further responses, and there are a lot of things being looked at. They're looking at they're looking at why the tumor is so immunosuppressive. It could be the other molecules, and that's where it's looking at, can we add in other molecules to kind of reduce that immunosuppressive effect and try to see, can we do better? So I think we do have work to do in small cells.
Yes, sir. Thank you, sir. Thank you, sir.